Oh, it's 9:40. You are mute.
Can you hear me?
Yeah.
Okay. Hi, good morning, everyone. Welcome to 155th session on 7th of October, 2023. We are meeting live on our CMAAO platform, and we are live on social media platform. Today we have yet again a very important topic. How can we protect kidney in our hospital care? I think one of the concerns we always have is what we're eating, how we can protect our body parts. Kidney is one of the most important thing. To speak on the topic, we have Dr. Prafull Chandra. He comes from all the way to Lucknow to give immense understanding about this topic. He's the director of Department of Internal Medicine and Diabetic Care for Health City Vistara Hospital in Gomti Nagar, Lucknow. He's also the director for Chandra Diabetes and Obesity Clinic in Vijayakhand, Gomti Nagar, Lucknow. Sir, over to you.
Thank you very much, Saurabh, for your nice words. Thank you, CMAAO, for giving me this opportunity. So, as discussed, we are going to talk about how should one protect kidney in the hospital care. So, what I wanted to say is that kidney is an organ which often gets unnoticed when a patient is hospitalized, and we often overlook the things unless there is something really bad which has happened. So maybe when patient goes in anuria, when patient's creatinine is raised or something deranged, then only we start noticing that there is something wrong going on kidney. So the best way to start understanding the risk which a kidney is exposed in a hospital, let me take up a simple case. I mean, why I'm taking this case is that once you go through this case, you can correlate at least, hundreds of cases that you might have seen in your hospital if you have an experience of a decade or more. Uh, and such cases are really very much frequent, and often we miss that. So there's a 78-year-old lady, and she was admitted to a surgical ward with left iliac fossa pain. So I'm just giving you, it was an acute diverticulitis. The another case could be, it could be cholecystitis, or it could be appendicitis. Any surgical case, a 78-year-old lady has come, and in the background she has CKD with EGFR of 35 ml. She is having hypertension. She is treated with ACE inhibitors, and for type 2 diabetes she is on metformin. Now, the story is this, that 1 week before admission, she had dysuria, and for which she was given some empirical treatment. It could be trimethoprim, it could be nitrofurantoin, it could be amikacin, or anything. I mean, empirical treatment was given to her without taking much or thinking much about what is happening to the kidney or what the infections are happening, and that usually do happen. So despite a poor oral intake during the week because of all these illness, we all know that people keep on continuing the medications. So she continued with anti-diabetic drugs, she continued with antihypertensive, and when she was admitted, she was febrile, 38 degrees C, and her blood pressure was low, blood pressure hypotensive, 80 by 50, and heart rate was 120. So we often see such cases. I mean, old lady with some chronic illness, with some pain abdomen, or say I would say some respiratory symptom, comes to you with a low blood pressure, increased heart rate, and having fever. Her oxygen was 96% on room air, and her urine output was decreased. It was 5 to 10 ml per hour. So what did we do? Now investigations were done. I'm going to talk about the staging of the AKI, how you determine the AKI. So her creatinine was 5.4. She had hyperkalemia, potassium was 7.1, and she was having high anionic gap metabolic acidosis. pH was 7.25, elevated lactate level, and CRP was raised. So this is what we have a patient, I would say, she is in sepsis. with metabolic acidosis. She has got hypotension, so she is in shock. Blood pressure is 80 by 50, heart rate is 120. So this is what she has come. And now once she is admitted, she has got GI infection, past history of some dysuria. She was treated with gentamicin, a common antibiotic. I'm just letting you know that what are the common scenario which we may have in our hospital. And apart from that, insulin glucose infusion was given for hyperkalemia. Now, since she was having hypotension, over next 4 hours, 6 liters of Hartmann solution was given. Despite giving 6 liters of IV fluids, she remained hypotensive and oliguric. I mean, most of us might have understood what is wrong going on with this patient in terms of management. Next day, her serum creatinine rose by a couple of milligram per deciliter. She became increasingly hypoxic with radiological evidence of pulmonary edema. She was transferred to ICU for mechanical ventilation. Vasopressors were started along with dialysis. A CT scan of abdomen was performed, which demonstrated perforated sigmoid diverticulum with generalized peritonitis. She underwent a left hemicolectomy, but 2 days later, while still on vasopressor dependent ICU, suffered a cardiac arrest from which she didn't recover. So, this is a typical case. Something went wrong. We were not adequately taking care of the kidney. We were not directing our therapy thinking about the background disease, taking it as a routine case, and ultimately she died. So the learning points here: the lady was at extremely high risk of developing AKI, which went unnoticed. She had pre-existing CKD. She is elderly with a significant comorbidities, and she was being treated on ACE inhibitors. So we had to withdraw ACE inhibitors. We had to avoid those drugs which was having higher chances of, causing kidney damage. Such patients should be identified early and counseled to temporarily stop potential nephrotoxic drugs. Even metformin should be stopped. We could see that she had lactic acidosis during periods of poor oral intake. So what it happens that when acute renal shutdown occurs, translating into rise in creatinine may take 24-48 hours time, and you may miscalculate the EGFR based on creatinine itself. The fact is that kidney may be in pure shutdown, proper shutdown, and even low dose of metformin may not be advised in them. In addition, trimethoprim should be used with caution in patients with stage 4 or 5 CKD due to its potential to cause hyperkalemia. So you have to identify the drugs which are safe and avoid all those drugs which is going to give trouble to the patient. Now, another point which went unnoticed or untreated was blood pressure. She was in shock. So it is essential to restore an effective blood pressure within first 4 hours of hospital admission. Giving blindly IV fluid up to the 6 liter was a wrong decision. So failure to achieve adequate blood pressure, which means mean arterial blood pressure more than 65 mm of Hg, despite an initial rapid infusion up to 2 liters of crystalloid, is a marker of severe severity. So what you have to do, you have to give fluid challenge. Of course, if there is low blood pressure, you give fluid challenge. You give rapid infusion, but don't give beyond 2 liters, because if patient's blood pressure is not improving even after 2 liters of crystalloid, there are chances that patient is in shock with peripheral vasodilation, and in that case, vasopressors has to be used early. So in absence of obvious fluid or blood loss or cardiac shock, which happened in this patient, such patients should be regarded as they are in septic shock, and they should be considered for early vasopressor therapy. In this case, additional fluid failed to restore an effective perfusion pressure, failed to improve renal functions, and contributed to development in pulmonary edema, and because of which we had to bring that patient or put that patient on ventilator and later on surgery, and ultimately she didn't survive. So finally, this case demonstrates the high mortality associated with AKI, where the renal insult is simply a talisman for serious underlying pathology. Now, with this background, let us understand what is acute kidney injury, how does it occur in hospital, and how does it affects the hospitalization. So acute kidney injury is common, expensive to manage, prolongs hospitalization, and is associated with increased mortality. Now, let me tell you that only 50% of the patients who have got some or the other kidney receive the actual or good standard of the care. The other way is 50% of the patient do get unnoticed. And what it has been seen that with the assessment of patient at risk of AKI, 60% of the post-admission AKI are predictable. So if you take the proper history, you can identify almost 60% of the patient who are at higher risk, and you can prevent acute kidney injury can be prevented in up to 1/5 of them. Now, out of the patient who develop acute kidney injury, almost 2/3 of them already have developed AKI before admission. You see this patient before admission, she already had compromised function. Her renal, urine output was 5 to 10 ml per hour. So 2/3 of the patient already have significant AKI before admission, and their diagnosis should be made. And for these, it is always said that some specialist intervention or some senior person who has got good experience in kidney or intensive care or critical care should come in the picture early and try to prevent all these cases, because more severe AKI is associated with worse prognosis. Now, what is the definition of AKI? So, AKI is defined by acute reduction in kidney function identified by an increase in the serum creatinine and reduction in renal output. Now, this is the usual definition which I was referring to. This is KDIGO staging classification, kidney disease improving global outcome staging system. Stage 1 means there is rise of creatinine in the range of 1.5 to 1.9 times in past 7 days, or urine output has decreased to half of the body weight per hour in for more than 6 hours. So if a person is having say 70 kg and if his urine output is less than 35 for more than 6 hours, that is a stage 1. If this urine output is less than 35 for more than 12 hours, it is stage 2, and here the serum creatinine has risen from 2 to 3 times. If serum creatinine has risen more than 3 times, which has happened in this lady, and urine output is less than 0.5 for more than 24 hours, we call it stage 3. There are other additional criteria, additional rifle criteria for reflecting outcome in AKI, which includes loss of the kidney function, which means patient needs dialysis for more ongoing dialysis for more than 4 weeks, and patient if requires dialysis for more than 3 months, it is called kidney failure. So this is how you classify the kidney, and more kidney damage and more severe is the kidney damage, worse is the prognosis, and this is what happened in our patient. Now, if a patient comes to hospital and develops AKI, these are the 3-4 trajectory which you can see. In few of the cases, I would say almost 60% of the cases, patient would go for recovery, but in another 30 to 40% of the cases, a chronic progression from AKI to CKD occurs. So it is always said that even when at the time of discharge, patient who had AKI in the hospital, you should keep monitoring kidney function of this patient every 3 months to 6 months, just to see if full recovery has happened or patient has went into deterioration to chronic kidney disease. So these are the potential outcome, and they should be taken care of. Now you have to identify who are the patient who are exposed to AKI or who have got higher risk of developing acute kidney injury. So it is important to recognize that two-thirds of episodes of AKI develop prior to hospital admission. So what I was trying to say, even in this case, that most of the time when patient is admitted to hospital, it is the worsening which continues. But if you are able to identify the onset of acute kidney injury, which usually occurs in up to two-thirds of the patient before admission, so that is the opportunity which patient gives you. At the time of admission itself, if you are able to identify who are at the risk of AKI or who have developed AKI, you will prevent AKI in these risk patients. So what are the risks? Include pre-renal, intrarenal, and post-renal. Pre-renal includes volume depletion, which may occur because of dehydration or blood loss, which may occur because of hypotension, like sepsis in this patient. There could be medications, I mean antihypertensive medications, diuretics, over medication, or cardiac failure. These are the things which can cause hypotension, leading to decreased renal perfusion and precipitation of AKI. Now, intrarenal causes like acute tubular injury that may occur with exposure to some drugs, interstitial nephritis, glomerulonephritis, vasculitis. Another example I'm going to talk about is going to be from intrarenal, intrinsic renal cause. And then post-renal causes, most often bladder outlet obstruction. Prostatism is very common in men. Bilateral ureteric obstruction, common in female and male both because of stone, and obstruction of the single functional kidney. These are common causes. So a good history, a good examination, I mean, even before going for any investigation, if you do a very thorough history, very thorough clinical examination, you will be able to identify almost all the patients who are going to develop AKI in the kidney, and truly said that two-thirds of the patient who develop AKI in the kidney, the process of damage has begun even before admission. Now, this is a very important, a little bit busy slide, but I would take a little bit time to explain because this is the crux of my whole talk. How to identify. So this is taken from Northern Ireland GRAIN AKI algorithm, and this is an alert system which has been developed there to identify cases early in the hospital and protect them. So what they have done is AKI risk assessment, in which they have taken some background factors. So CKD less, I mean EGFR less than 60, age more than 65, or comorbidities including ischemic heart disease, congestive heart failure, or diabetes mellitus. Then acute context includes sepsis, perioperative period, illness severity like hypovolemia, hypotension, deteriorating, or medications used like NSAID, COX-2 ACE inhibitors. So if patient has got two or more risk factor, even at the time of admission, they are considered as AKI at risk patient. And in these patients, daily urine examination is done, close urine output recording is done, and close attention to fluid balance is done. So this is how you have to identify people who are at risk of kidney damage in the hospital, and then in them you have to intensify the monitoring so that you can identify them early. Now, if somebody develops AKI, what are the features? So if serum creatinine rises to more than 2 times in 48 hours, or more than 50% from baseline value, or urine output is less than 30 ml per hour for 6 hours, these are the patient who has developed AKI. So you have to prevent the further damage, and you have to bring early recovery. So you have to do some investigations to find out the cause. So urine examination, blood sugar, CRP, LFT, glucose, blood coagulation profile, urinary sodium. Then for urine ultrasound, just to find out if there is obstructive lesion. So within 6 hours, if upper tract obstruction is considered, within 24 hours, if AKI is not responding to treatment, then in selected cases, you may have to go for some tests which include whenever you are thinking about intrinsic renal causes, you may have to go for ANCA, anti-GBM, and all those things have to be done. Then how you have to protect? The first thing is that you have to restore kidney perfusion. The best way to prevent further damage to the kidney is to restore the perfusion early. And how you have to do? You have to give bolus of 250 to 500 ml of crystalloid, targeting systolic blood pressure of more than 100, and clinical evidence of euvolemia. A maximum of 2 liters of IV fluid should be given in 2 hours. Now, in this patient, despite inadequate response to IV fluid, 6 liters of fluid was given overnight in 12 hours. That's why the patient developed pulmonary edema. It says that even after fluid challenge, up to a maximum of 2 liters in 2 hours, if there is no improvement in blood pressure, consider that patient has got shock, peripheral vasodilatation, and in them vasopressors should be used. So after each bolus, check for sign of fluid overload. Optimize blood pressure if despite adequate fluid challenge, hypotension persists, which means systolic blood pressure of less than 100 or mean arterial pressure of less than 70. You should go for vasopressor. You should involve senior persons who could take decision about it. Another thing, when patient is admitted, prescribe safely. So this patient was having ACE inhibitor, that is perindopril, and she was given some aminoglycosides. So avoid those drugs. Even in any admitted patient whose blood pressure is less than 120, you should avoid any antihypertensive and diuretics. Choose the correct antibiotic, so aminoglycosides or even metformin, sulfonylureas, these should be avoided when blood pressure is less than 120. IV fluid prescribing pattern, you have to maintain adequate fluid, so urine output plus 30 ml as insensual loss per hour is what it should be done. And if potassium is more than 5.5, you should avoid Hartmann solution because it has got potassium in it. Now, there are certain conditions where we should involve our nephrologist friend early in the management. So when you suspect intrinsic renal disease, or there is potential need for renal replacement therapy, or AKI is occurring, in these cases, we need to involve our nephrologist friend early. Now, let us understand a little bit about pathophysiology of pre-renal AKI. So once you understand the pathophysiology, you will, what it is always said that eyes see what your brain knows. So once you know the pathophysiology, you can identify the things very early in your clinics. So there are certain factors which increase susceptibility to renal hypoperfusion, which include, and that ultimately leads to failure to decrease arteriolar resistance. So if arteriolar resistance doesn't decrease, so if afferent artery which goes to the glomerulus, that is responsible for supply of blood to the glomerulus, so adequate flow should occur to the glomerulus so that kidney is protected. And if adequate arteriolar dilatation does not occur, hypoperfusion occurs. So that include some structural changes which occurs with old age, atherosclerosis, hypertension, and chronic kidney disease. Reduction in vasodilatory prostaglandins when patient is receiving NSAID or COX-2 inhibitors, or if patient's afferent glomerular arterial vasoconstriction is there, which usually occurs in sepsis, hypercalcemia, hepatorenal syndrome, and certain drugs and radio contrast. So these are the background where patient may develop. So if patient is developing AKI, try to find out if there is any risk factors like this. If there are, please stop it. Please stop the insult which is happening to the kidney. Try to improve the perfusion by adequate dilatation of the afferent arteriolar. Then efferent arteriole should have, often there is dilatation and that leads to decreased EGFR. So angiotensin converting enzyme inhibitors and ACE inhibitors and ARB are important factors which has to be taken into consideration. Now, from intrinsic, let us move to hypoperfusion, the hypovolemia. So identify if there is gastrointestinal or renal loss or skin loss. There could be cardiac causes. patients who are in cardiac failure, tamponade, or valvular disease at higher risk. So if you see any of these factors in your patient, identify and prevent. Reduced peripheral vascular resistance, which occurs in sepsis, hepatorenal syndrome, drug overdose, or vasodilator drug. Local renal perfusion, which includes renal artery stenosis and malignant hypertension. So, with prompt restoration of intravascular volume and blood pressure, normal renal hemodynamic can be restored, which may result in complete recovery of the renal function. So, you have to identify these factors and you have to address these factors so that adequate perfusion to the kidney is restored early so that further damage is stopped and early recovery occur. Now moving to prevention of AKI, the first thing I told you that almost two-thirds of the patient who develop AKI in hospitalization have already onset of AKI even before admission. So those patients has to be identified, and in them you have to prevent development of AKI. So if patient has got CKD, EGFR less than 60, and patient with normal renal function who are being treated on ACE inhibitors or who are on NSAID, they are having hypertension. If they develop hypovolemia, these are the patients who are at risk. Please identify them early. Provide instructions for temporary cessation of certain medication which may in this setting induce or exacerbate, complicate AKI. So all those drugs, ACE inhibitors, NSAID, these are the patient. Whenever they develop hypovolemia, hypotension, keep them instructed that, well, if you develop low blood pressure, stop these medicines. This lady should have stopped perindopril, I would say, at least 6 weeks back when she has started having developing all these symptoms. And the best way is a mnemonic called DAM. These are the four drugs which should be avoided when a patient develops hypovolemia or hypotension. This include diuretics, ACE inhibitors or ARB, metformin, and NSAID. So these are the four commonly used drugs which ultimately exposes the patient to acute kidney injury. So whenever a patient of hypertension develops hypovolemia, I mean, these are the four drugs we should certainly tell them to stop early. Now, there has to be a risk assessment tool at the time of admission itself. So, all patients, both on admission and during their hospital, should be assessed through this. So, if there are comorbidities, I told about comorbidities, two, three comorbidities were there. Ischemic heart disease, heart failure, diabetes, COPD, peripheral vascular disease. These are the comorbidities. So, if there are more than two comorbidities, if baseline EGFR is less than 60, systolic blood pressure is less than 10, patient needs IV fluid or patient is on nephrotoxic medication. If the score is more than 3, these patients are at higher risk of AKI. Close preemptive management has to be done to prevent AKI. So, once again, this is a repetition. Age more than 65, CKD, comorbidities, nephrotoxic drug, hypovolemia, hypotension, deteriorating early warning. These are the things which has to be identified early, and then they have to prevent it. Now, another common scenario where we see AKI is surgical cases. Old patient. I would say we do have in our center. We do have more than 50 total knee replacement. Because of osteoarthritis per month. And I would say that almost all of them are more than 60 years of age. They do have comorbidities, hypertension, diabetes, and we do see AKI in them very frequently. So, what it has to be brought in, you have to have a checklist to identify who are the patients, and in them you have to take measures to prevent AKI. So perioperative AKI is common. Recognition of patients who are at risk should be done, and then risk factors as given in this chart should be done. So if elective intra-abdominal surgery, emergency intra-abdominal surgery, or comorbidities, or baseline GFR less than 60, I mean, risk factors are same. The message is that risk of developing AKI in which set of patients is common, identify those patients, do preemptive management so that you are able to prevent the kidney injury. So if risk score is more than 30 in these patients, daily urine examination, you should follow AKI protocols, And if creatinine rises by more than 30 from baseline values, all these cares should be taken to improve renal perfusion. Close recording of urine output should be done. If blood pressure is less than 130 by 80, antihypertensive medications should be stopped. We should not use NSAID or aminoglycosides if EGFR is less than 30. ACE inhibitors and ARB should not be started early after surgery. You should wait at least for 48 hours after surgery. And if hypovolemia or hypotension is present, resuscitate as per AKI protocol, which I have already stated early. Now, how to prevent AKI in perioperative period? Optimization of fluid balance has to be done. Fluid volume status should be carefully assessed with respect to both fluid depletion and fluid overload. Patient at risk of dehydration due to prohibited or poor oral intake should be prescribed maintenance IV fluid. So this is another common thing. Patient has to be taken on surgery. Patient is said that you don't have to take anything orally from after 12 in night, and surgery is planned at 7 in the morning, and it gets delayed. Maybe surgery occurs at 11 a.m. So patient is getting dehydrated because of 12 hours of nil input. So whenever you put a patient on nil oral, you need to prescribe maintenance fluid so that their volume is maintained. Optimization of blood pressure, so hypertension, systolic blood pressure less than 110 or mean blood pressure of less than 65 needs urgent assessment and treatment with IV fluid challenge and vasopressor agent wherever indicated. Medication review, I have already told that DAMS, that is diuretic, ACE, ARB, metformin, and NSAID. These are the drugs which should not be given to these patients. Another group where AKI occurs, that is contrast nephropathy. You have to identify the risk and you have to manage the risk. So risk is higher when EGFR is less than 30 or in between 30 to 60. In all those cases, it is said that proper hydration should be done. So soda bicarb 1.4%, 0.9%, a normal saline at 3 ml per kg per hour, 1 hour prior, and up to 6 hours after the procedure, these drugs should be given to prevent the acute kidney injury. Omit potentially nephrotoxic drugs, ACE inhibitors, ARB, NSAID, and metformin at least 48 to 72 hours before, and should not be started 2 to 3 days after the procedure. Use low osmolar agent and recheck renal function after 48 to 72 hours. So to prevent contrast nephropathy, these are the procedures which has to be done. uh, Now, there are a few words about clinical assessment. If a patient develops AKI, this should begin with search of AKI, focusing on clinical evidence of hypoperfusion. AKI in the setting of resistant hypotension suggests significant underlying sepsis, the source of which may not be immediately apparent, especially in case of intra-abdominal sepsis. That is what it happened in our index patient. Intrinsic renal disease in the form of vasculitis may have some other features like typical rashes, uveitis, and arthroplasty. Though arthropathy, these should be identified. Intrinsic renal disease should always be considered when AKI is occurring in absence of significant dehydration. So you have to do an adequate clinical assessment. Try to find out if it is because of hypertension, hypovolemia, or if it is because of intrinsic kidney disease, or is it because of post kidney obstructive disorder. So, and that has to be managed appropriately. The first thing is that diagnostic urine analysis should be done. If you find blood cells, then probably, if you find the RBCs in the urine, then probably there is some intrinsic factor which is responsible. So hypoperfusion states are suggested by raised urine specific gravity. So pre-renal specific gravity of the urine will be increased. In absence of hemodynamic upset or sepsis, presence of blood and protein in urine would prompt consideration for intrinsic renal cause, including vasculitis and glomerulonephritis, rather than urinary tract infection. So that should be done. Once a patient develops AKI, proper evaluation should be done. Anemia and thrombocytopenia with normal coagulation profile should prompt for search of hemolysis, which occurs in hemolytic uremic syndrome. Chest X-ray can be done both to find out evidence like pneumonia, pulmonary shadowing, which is seen in vasculitis. Renal tract ultrasound should be done within 6 hours wherever obstruction is considered. Otherwise, it should be done within 24 hours when Patient is not responding to initial measures. Presence of AKI should not prevent use of contrast enhanced CT scan. However, you should appropriately take measures so that damage does not occur, and you should try to identify if there is abdominal abscess or ischemic bowel. Early management of established AKI is very much important. You should restore renal perfusion, then optimize intravascular fluid volume. Volume status should be carefully assessed, and attempts should be made to categorize patient into one of the three. Either patient is hypovolemic, euvolemic, or hypovolemic. In hypovolemic patient, fluid challenge has to be given. So patient may have signs of clinical dehydration, patient may have oliguric, patient may have concentrated urine. There is no gold standard to definitely identify dehydration. However, hypotension, that is blood pressure, systolic blood pressure less than 110, and a postural fall in blood pressure with increase in heart rate, reduction in perfusion pressure, skin turgor, suggests that patient has got hypovolemia. Hypovolemia should be promptly corrected with repeated bolus of 250 to 500 ml of crystalloid up to 2 liters in 2 hours. And if this hypovolemia correction within by 2 liters within 2 hours is not able to give adequate blood pressure response, vasopressors should be used. Now there is another group of drug, euvolemic patient who may have dehydration. As this lady, euvolemia is characterized by absence of clinical signs of dehydration. Patient although may have hemodynamic instability, but there would be absence of fluid overload. Oliguria in this context reflects established acute tubular necrosis, will not respond to increasing fluid challenge, which put the patient at the risk of fluid overload. So if you give on, keep on giving fluid beyond 2 liters after 2 hours with inadequate response in blood pressure, there are chances that patient will develop fluid overload and ultimately pulmonary edema. Fluid intake should be restricted to a matched daily output. So in these patients, don't do over enthusiastic fluid replacement. The best way is to give crystalloid urine output per hour plus 30 ml. That is the standard that you should take. So if patient's urine output is say 30 ml per hour, then you can add 30 ml. 60 ml per hour is what you should do the fluid replacement in patients who are euvolemic. In hypervolemic patient who have developed AKI, you have to identify them. The features which identify hypervolemia include raised jugular venous pressure, peripheral and pulmonary edema, which can be seen. Calculation of total fluid balance since admission should always be done, because over-enthusiastic fluid replacement is the most common cause of hypervolemia. In presence of AKI, hypervolemic patients are vulnerable for pulmonary edema, and in them fluid restriction should be done. If there is no definitive evidence that use of loop diuretic may help in these patients. However, short trial of loop diuretic can be given in these patients when patient has got pulmonary edema and blood pressure is adequate. Failure to respond would need hemodialysis and ultrafiltration, which this patient required. Now, a few words about AKI and hypotension. How to keep blood pressure. So blood pressure should be targeted to mean arterial pressure of more than 65 mmHg. So this can be achieved by three interventions. You should withhold drugs which affect renal autoregulations, which include ACE inhibitors, ARB, and NSAID. Temporary cessation of all drugs that induce hypotension. This include hypertensive drug, antihypertensive drug, diuretics, and agents like nicotinidiol and opioid. Consider vasopressor like noradrenaline in patients with refractory to adequate correction with hypovolemia. Vasopressor should be considered early in such patients to avoid needless fluid overload. It should be stressed that there is no evidence of a role of renal dose of dopamine in management of AKI. I would say about 2 decades back when we were doing our graduation, we often heard about renal dose of dopamine, but evidence have come which suggests that renal dose of dopamine doesn't have any role in protection of kidney. In addition, dobutamine has significant vasodilatory effect which can aggravate hypotension and worsen renal perfusion, so that should be avoided in patients with AKI. You should prescribe medicine safely. Time and again, I have repeated this. Avoid DANs, that is diuretic, ACE inhibitors, metformin, and NSAID. The reason is this: in most of the patient, there is background risk of acute kidney injury, and exposure to nephrotoxic drug ultimately precipitates AKI. So, if patient has got high risk, you should avoid it. You should prescribe medicines safely and avoid all those drugs which are associated with renal injury. Avoid those drugs which aggravate hyperkalemia, like trimethoprim, potassium sparing diuretics, which include spironolactone, amiloride. In addition, both beta blocker and digoxin can inhibit sodium potassium ATPase pump. So that should also be avoided. Presence of these drugs render patient resistant to insulin glucose transfusion. So beta blocker and digoxin, they as such don't inhibit insulin glucose transfusion, but they inhibit
He joins back. Uh, does anybody wants to speak on this topic? Please go ahead, Dr. Angelico.
Morning, everyone. I'm so glad that you have this topic on. For me, as a general practitioner, this is one of my most problematic chronic diseases, and it is much, much underestimated by not only the specialists, but at primary healthcare, where, as Dr. Chandra correctly said, it should start, the prevention should start at primary health. And if we look at the type of patients having this disease, it is unfortunately our older patients who have rheumatoid and osteoarthritis and backache, and they use indiscriminately NSAIDs over the counter, and they also have, to put insult to injury, hypertension and diabetes, and doctors doesn't understand the role of metformin in CKD. If you can prevent the patients having this before they're going into theater, you will have a great outcomes in the end of the day. So I'm so glad for this presentation. It is really, Dr. Chandra's presentation is absolutely necessary. Thanks.
Absolutely, Angelica, thanks for your comment, and I'm sure this topic.
I'm sorry, I got disconnected. I'm sorry.
Okay, so we have the speaker back, and we will let him continue before we can take over the session. Dr. Chandra, over to you.
Perfect. So there were only a couple of slides left. I was just going to conclude. So let me continue that. So this was the second case that we did have. And I was just trying to show that if you take care of these things very, adequately, things are going to happen. So he was prescribed doxycycline and NSAID 1 week previously. He had background of type 2 diabetes and hypertension. So he was treated with ramipril, and on admission he was having fever with hypoxia. His blood pressure was well maintained. White blood cell counts were raised. So there were chances, we thought that patient has got pneumonia. Patient was at high risk of developing AKI. Background of diabetes, background of ACE inhibitors, patient has got sepsis, patient had received NSAID. His creatinine was raised, of course. Then we tried to identify the cause of the cuff. Chest X-ray was done. Multiple nodular opacities were seen. So despite treatment with antibiotics, his renal function kept on deteriorating. So this was the point which suggested that there is something other than infection. So a repeat urine analysis was done, and here blood and protein was seen. Then a subsequent some referral from nephrologist was done, and vasculitis was seen in this patient. And then his presentation was consistent with granulomatosis with cholangitis. He was empirically treated with methylprednisolone and IV cyclophosphamide. Subsequent renal biopsy was done by nephrologist, and they did see vasculitis. 2 months after the presentation, GFR was 50 ml. His pulmonary nodules had resolved. So what we learned out of this patient was initially suspected to have AKI due to combination of pneumonia, concomitant NSAID, diabetes, and ACE inhibitor. However, there were three key pointers to possibility of intrinsic renal insult: lack of hypotensive insult during his hospitalization, presence of deep blood and protein, and failure to improve despite appropriate antibiotic therapy against pneumonia. So this is how we should prevent kidney injury in our patient, and mm, try to help our patients who are admitted. Thank you very much for your patient hearing. I will stop sharing now.
Thank you, Dr. Chandra.
Back to Saurabh. Yeah, thank you.
I think this topic is very sensitive and very personal to me because I lost my dad because of the kidney failure while he was being admitted for the heart attack, and his everything was being sorted out. His diabetes was being taken control, but I think eventually we lost him because of the kidney failure.
So now you can correlate the things, how the things do happen very much commonly in our hospitals and usually gets unnoticed until the disease is quite advanced.
So we have Dr. Chong with us, and I will ask him to speak something on this topic and take over the session. I would also like Dr. Monica to speak on this topic. I'm sure we have had a lot of discussions on it. So over to you, Chong.
Thank you, Saurabh, and thank you, Dr. Chandra, for that wonderful presentation on AKI. Yeah, it's in Singapore, for example, we still have about 1,000 new cases of end-stage renal failure every year. Most of it is due to diabetes because of a huge rate of diabetes in Singapore. 10% of our population are diabetic, so that's a huge challenge. And very often, a lot of patients come into hospital or even come into a clinic with high baseline creatinine. And we all know by the time a creatinine is abnormal, actually something like 50% of the renal function is already impaired. Yeah, so a lot of my patients, for example, when they come in and do blood tests, will always do a microalbumin as well. I find EGFR not great, if you know what I mean.
I agree.
I find, because when I graduated, there wasn't an EGFR before. So I found it not very helpful, but I found this urine for microalbumin quite useful to identify early renal disease in a lot of my patients who are otherwise quite well. Yeah, so that's all I have to say for the time being. Monica, anything?
Yeah, thank you very much. This is a very great topic. I will tell you that what Dr. Kotze had said earlier is a great summary. That one is understanding who has CKD, understand the risk of CKD, what is their underlying factor towards CKD, having a patient awareness of the use of NSAIDs and other nephrotoxic drugs. But Dr. Chandra, being in the inpatient, I think is extremely important, because if they're coming in for an unrelated medical issue, I think you are like absolutely right to raise the level of awareness that CKD, AKI risk, at-risk patients need to be prioritized as part of the admission diagnosis so that everybody remains vigilant in these high-risk scenarios. And I think it takes a very concerted effort, especially if somebody comes in with a stroke, if somebody comes in with a heart attack, or somebody comes in with an acute issue, that that creatinine needs to be obtained. It needs to be assessed compared to what their prior creatinine is, and to make sure that anything that is potentially nephrotoxic is avoided, the patient is hydrated. And you gave amazing pearls, like in terms of volume repletion and use of colloids and making sure that it's less than 2 liters. There was a lot of granularity in your presentation today, and I think everyone should go back and listen to their patient scenarios, because you gave us a lot of amazing information. And if we keep the kidneys happy, we will always improve the outcome of all these patients. So thank you for a fantastic presentation.
Thank you. Just I wanted to, add a couple of things once again. Maybe when we graduated, we were not using EGFR, but now radio reckoner EGFR calculators are there, and at least we have developed the habit of, writing down EGFR even in our OPD patients. That gives you an alert. Okay, well, if EGFR is less than 60, this is an alert. I agree. When patient is admitted, creatinine alone may not be helpful. Probably urine evaluation and finding out urine output gives you idea of kidney injury earlier than what EGFR would give. But if you put EGFR at the time of admission itself, it gives you a flag that, well, this is the patient who may develop something wrong, and in them you have to do regular urine examination. That is what I was trying to identify. If patient is at risk, do urine examination daily basis, try to find out albumin, try to find out urine output, and those are the patients who should receive priority in terms of monitoring their renal function. And that is why I found EGFR to be very much valuable even in our OPD practice. IPD, of course, we should do that. Thank you.
Noted. I agree. I just said that what I meant was that EGFR wasn't that useful in terms of assessing the actual renal function, because is a measurement of creatinine versus a lot of other factors. But I agree with you that actually having an EGFR reading does it gives a flag to the physician looking after the patient. It just puts the fact that renal function is very important right up there.
Yeah,
I agree with that. But it's a challenge especially in Singapore. We have a high diabetic rate. We still have a lot of patients walking around with CKD and undiagnosed, obviously. And in my practice here, we have a full radiology suite. So we're very obsessed about creatinine before we give contrast. Yeah, because we've seen it happen. So contrast and scans is
here in
not
Lucknow
laughing
also.
matter.
Yeah. Here in Lucknow also, if patient has to go under contrast, it is mandatory to, go for serum creatinine, measure EGFR, and if it is more than 60, then only they go. Otherwise, they send the patient back and tell us that prepare the patient for contrast, then only we'll go for contrast. So that is a protocol that we do have in our setup also in the radiology department.
But it was very interesting, your case of Wegener's granulomatosis with anchor. Very interesting case. I haven't seen one of those in many, many moons.
Fortunately, we do have a good nephrology team, and they come up very early for help, and they keep us teaching all these things. So it was a good case, and I thought it would be good if I pointed out.
What a lot of people don't realize is as a renal physician, actually you're all very, very good general physicians.
Yeah.
You have a very holistic picture of the patient, and it's not just the kidneys. I mean, because so many things can affect the kidneys. So you guys have actually a very nice helicopter view of the patient, especially when it comes to inpatients, complex inpatients, ICU patients. I find the renal physicians have a very good grasp of the general picture of the patient. It's actually excellent general internal medicine training, nephrology.
Yeah. I agree.
Anything else from the floor? Anybody has any comments or any questions?
Good morning, Dr. Chandra. Excellent presentation.
Thank you, sir.
To me, is the primary health physicians or primary health clinic. Most of our patients visit in basically for minor or any other condition. What happened in primary health care? We do blood pressure, we do HGT or blood sugar. We don't do routine, people don't do routine urine dipstick. And that's a very, very gross. You can, one drop urine can pick up whether there's albumin or red cell or blood cell or cast. And that's the basic screening area. and we miss a lot from there. And that by the time we see patient, it's already hypertension, already complicated diabetics. So I think we need a campaign that every primary health clinic must do urine dipstick. Like a pregnancy patient go to the clinics, they have routine urine test and hemoglobin and blood sugar. So we need to start somewhere, very basic screening. Thank you, Dr. Chandra. Your opinion?
So I really agree. These are the habits that we have to develop in our clinics. I just told you that whenever patient comes to me in my OPD, I mean, if there are any risk factors, these are the things I usually do. I calculate EGFR, I get urine test done, and I put it as headline in my prescription. I mean, the way you write blood pressure, pulse, oxygen level, body weight, BMI, I put EGFR also. I put urine evaluation also on the top line in my patient assessment. So these are the red flags. Particularly, see, I'm dealing with patients, mostly diabetic, hypertensive. Most of them are more than 50 years of age. They are at risk. So this is a habit that we have to inculcate in ourselves. And I really agree to you, Dr. Hussain, that this is what we should develop. We should develop the habit of identifying patients who are at risk so that we can prevent. Thank you.
Fascinating. I was just in Dhaka for our CMAAO meeting, and they presented the community clinics across Bangladesh. And the healthcare worker there can measure three things: one, blood pressure; two, urine lab stick; three, blood glucose. And from there, they pick up a lot of patients with CKD and so on, and move them on to the next level of care. Yeah, so that was pretty interesting, that they empower the health worker to do these three simple things, and they pick up a lot of chronic disease, a lot of CKD, etc.
I agree.
Any other questions from the floor? If not, we'll thank Dr. Chandra for this wonderful presentation, and that we got us all thinking about AKI and CKD. Without much further ado, thank you very much again, Dr. Chandra, and it was wonderful having a nice overview of AKI, CKD, and and their relationship to complex inpatient situations, as well as to common everyday outpatient scenarios. Thank you very much, and see you soon.
Thank you. Thank you very much. Bye.
It was absolutely a pleasure. Yeah, Ravi, please go ahead.
Bye.
Chandra, for joining in the session, and this brings the end of the last session. We will see you again next week or next to next week, and the speaker will be announced soon. Thank you everyone for joining in.
Thank you.
Thank you. Bye-bye.
Sarah.
Thank you.
Thank you. Bye.